Welcome. For those of you I have not yet had the pleasure of meeting, my name is Sherry Wicker. I am the Associate Director of the Office of Continuing Professional Development and the Director of our Teaching Academy, Teach. If you have not yet had a chance to sign in, please remember to do so. Sign in is out front. It will be there after this session as well. So, without further ado, I'm going to have Dr. Very introduce Dr. Haramati. He knows him very well, and we'll give you a little bit of insight into what we can expect today.
Thank you, Sherry. I'm Rick Very. For those of you who don't know me, I'm at the medical school across the river. I'm the Senior Dean of Academic Affairs, and so my main area is the curriculum, medical education, and I've been here with the school since it started. Going back another time frame, I've been with this guy since around 1977. We were at different schools together, but we're both trained as renal physiologists, and so he's been my uncredited, I think, secret mentor in guiding my career through many years, and I'm just so happy that he was able to come and visit us yesterday. We had a lot of faculty development sessions, some sessions with our students on some topics that we can't normally get in the curriculum, but we wanted to have a session with hospital people on this topic, which is a very hot topic in healthcare these days. Dr. Haramati is a distinguished, internationally known, not only renal physiologist, but medical educator. His CV is 100 pages long. He's got tremendous record of academic accomplishments. He's now started several centers at Georgetown that he might want to talk to you about. One is part of a teaching academy, the Centile, which is a leadership program in education. But he's also now very interested in becoming a national leader, an international leader in stress and burnout and resiliency, not only for students but also for healthcare workers. And so, Adi, we're honored for you to be here, tremendous friend, and thank you all for coming this early day. We've worked, he said, worked me to death, and we just about have.
Thank you. Thanks, buddy. Good morning, everyone. Let me just make sure that I've got all the mics on. Am I okay? I don't need the other one, do I? No. Okay, great.
The video camera, have you unmuted?
I have.
Okay, you're good.
All right, good. So I'm impressed that after an evening of surprises, and I would assume not a lot of sleep, you're coming in here to learn about stress. Well, let's focus on resilience. How's that? I think that's the idea. So thank you, Dr. Very. How many of you are physicians in the room? And how many of you are nurses or other health professionals? And the rest of you are family members, I think. I'm not a clinician. I deal with medical students. And what I've noticed over I've been at Georgetown 32 years in a variety of capacities. And it's clear to me that in the last decade, there's been an acceleration in the stressors that the students are going through for lots of reasons. Society as a whole is in that situation as well. And it's particularly affecting physicians. And I know you know about that because many of you in this room and in this hospital have been looking at this issue seriously. So I want to talk to you about an approach that we've begun at our medical school. Perhaps we could extend it to other places, and then put it in the context of a national movement. And that's why I've titled it Managing Stress Building Resilience, and then taking a piece on mind-body medicine as an innovative intervention for our students, for faculty, for physicians, for all health providers, healthcare providers. And I'll try to make a case why I think it's an imperative. I'm going to start with disclosures. I joke that my wife actually isn't so happy I don't have any conflicts of interest. We've got, and I'm also not a cognitive psychologist or a mental health professional, and I will be talking about these issues. I'm a renal guy, and so just keep that in mind. But I'm an educator, a skeptic, and I do have an open mind. And the skepticism took me to places I didn't imagine, and the open mind actually convinced me that there's something to this idea of using mind-body medicine. So let's begin by asking this. Does this look familiar? You could say yes or no. How about this? You're actually pretty good. Usually I have at least 2 people that are still on their phones 5 minutes into starting. And the truth is we are always connected. It's the way we are. And then how about this? Does this resonate at all? With this physician burnout title, and Mrs. Johnson says, "I feel the way you look." Yeah, we joke, but it's actually not so funny, right? I mean, this is the problem. So here's what I want to talk about in about 45 minutes. I do want to address physician stress and burnout briefly. I know you know quite a bit about this. I want to maybe pull out what I think are the key issues on that. And then I want to turn to the physiology of stress, because I want to establish a hypothesis. Why is this happening? And why physiologically are people in that situation? And then begin to look at tools that individuals can adopt, perhaps to reverse that. We're not going to solve the whole burnout problem, but we can certainly address things individuals can do. And why I'm going to end with despite the situation, and you can extend that as a metaphor for the nation, there is cause for optimism, because there are things we could do. So, and if you have to leave early, here's the take-home message. Simple. Physician stress and burnout are serious. They're widely prevalent. And I believe that it's on a continuum that begins way back in medical school with the erosion in empathy and erosion in well-being that students exhibit. And that we have a responsibility as a place where students train to really give them the tools to succeed. And so we need to establish curricular interventions to help students and faculty manage stress, foster empathy, build resilience. And that has to be incorporated not for individuals on an elective, but actually into the culture of the institution. That's new. And it's at the medical schools, and it's also in the hospital setting as well. That's what I'm going to get at. So we'll begin with the issue of burnout, and Christina Maslach, who developed the Maslach Burnout Inventory back in the 70s, is a research professor at Berkeley, and describes burnout not as this, acute event. You get a phone call, oh my God, I heard this terrible news and now I'm burnt out. But rather it's the accumulation over time of things that build up, and eventually you reach the point where you don't want to come to work, or you can't. It's a problem. So how does burnout manifest? Her scale, for good or bad, has 3 subscales. So there are 3 characteristics. The first is emotional exhaustion. And that is essentially the way it sounds. You're spent. There's nothing in the tank. You have given and given and given to others, and now you really have nothing left. In a health service, in a service industry, this is a problem. Depersonalization is something that also happens to physicians. That is that you lose the ability to look at people, at patients as individuals, as human beings, and rather they become objects. And for many in the burnout phase, although interestingly not so much for physicians, taking back 20, 30 years in a career, and all of a sudden you look at what you've accomplished and you wonder with this very negative sense, is this all I've done? And so that spirals into thoughts of inadequacy. And the problem is that with these combination of traits, there's the inability to express empathy. Again, for a service industry, this is a problem. So what are the statistics? I know you know this, but I'll just give you my take on this. So based on Shanafelt's 2012 study in Archives of Internal Medicine, we know that 1 out of 2 physicians experiences burnout. In practice, has at least one element of those 3 in the past year. And it's not just physicians. It's actually all healthcare professionals, nurses, pharmacists, PAs. And for those that are interested into which specialties we're talking about, the top of the food chain, the most at risk are emergency room physicians. And right below that is general internal medicine, and you see neurology. What just happened? Okay. Let's go quickly back. General surgery, which you would think would be higher, is actually right at the national mean, and right at the bottom, even preventive medicine and occupational medicine, environmental medicine, you see dermatology and pediatrics is above that, but it's still, let's go back, you see it's 35%. So it's still, as I'm looking right at the pediatrician. So these are serious numbers, and it's not just the United States. Here's Canada just above us. And what do you notice on this 50% burnout of resident doctors? Here are the 3 dimensions. This is where it leads to, and we begin to look at what's the problem. 2/3 feel the workload is too demanding. Half think that deprivation affects the care that they give, and for many, the personal lives have suffered. And I can go on to other countries. So this is not unique. This is linked to the profession. What I do want to share is the data from their latest study at Mayo. This is Tate Chanafelt and Colin West and Lottie Derby and their team. And so they published this paper in Mayo Clinic Proceedings that looked at what happened since 2012. So taking the data from 2011, they published it in 12, and then follow up 3 years later. And what you notice here in this title, they're looking at burnout and satisfaction with work-life balance in physicians compared to the US population. So here's their data in a nutshell. And I'm showing you this because this is not a static situation, it's a train wreck in slow motion is how I see it. And so in the upper panel is burnout, and what you notice here is the general population at around 30%, and you notice physicians are higher in 2011, and they're getting worse. In fact, it exceeded 50%, 54%. At the same time, if you look at satisfaction with work-life balance, the general population is over 50% satisfied, and actually got more satisfied over the 3 years, while physicians got worse. In other words, the gap between physicians and the general population is getting worse, which means we can't not do something about it. And we've been talking about it for a solid 10 years, that it's serious, and now it's getting people's attention, I would say. Now, when we had Colin West come to Georgetown because I want him to really advise us on how we're going to address our entire institution. And at Georgetown, we sold our hospital to MedStar Health. And so MedStar Health, that owns 10 hospitals and has 1,200 residents in their entire system, they're very interested in really assessing the entire workforce, essentially where we are. So this slide from Colin West says that there are really 5 drivers that they've identified that are causing this. And some of these will make sense to you. In fact, you might resonate with this, but certainly the excessive workload that physicians experience is a driver. The inadequate support and inefficient work environment. You can point to the electronic medical record here, or the health record, and basically say this has been a real issue. And you can add other administrative tasks that are just adding to this. Problems with work-life integration and balance is pretty obvious. Everyone's struggling with that. Loss of autonomy and control, what that's about is many physicians don't control their own schedule. They're in someone else's hands. And that sense of lack of control is very stressful. And then for many, the loss of meaning in work. There's a slide which I'm not showing you, but I'll tell you, is that if you assay basically the physician population, 30% would not go back into the field. And in some specialties, it's even higher. So there's serious issues. And you wonder, so what's the implication? So let those people leave. Well, it turns out that physicians that are burnt out commit more errors. You can see how it adversely affects the patient-provider relationship, and ultimately there's a decrease in the quality of care. Are you depressed yet? There's good news. Let me start with the good news. So the beginning of the good news is last October, the center that I direct at Georgetown partnered with our health system, and we invited 6 institutions to join us, and we within 9 months put together an international conference to address educational issues. What are we going to do to promote resilience, empathy, and well-being in the health professions? And the idea was, what interventions are beginning to show promise? We don't need to focus on burnout. We know the issue. What are we going to do about it? What are we going to do individually? What are we going to do organizationally? And our first speaker was Christina Maslach, actually, to set the tone for what are we learning at the moment. And so this is her slide, in which she said, here's the issue for burnout. It's not just about the physicians, if you will. It's about the incivility in the workplace. It's about health problems in the workplace. And it's ultimately about higher costs for the organization. And that's actually what's getting people's attention. What we want is resilience. So let's focus on that. And for that, we had Stephen Southwick come. I don't know if you know who he is. He's a psychiatrist at Yale. He wrote the book, The Science of Resilience. He did studies with Dennis Charney, who's the CEO at Mount Sinai. And I invited him to come and speak. First day was on burnout, second day was on empathy, third day was on resilience. To talk about what is it about resilience and how do we get there? So first, a definition. What does resilience mean? The American Psychological Association defines resilience as the process, as you see, you could read like faster than I can, about adapting well in the face of trauma. Adapting. I don't think that captures it. And so I like Epstein and Krasner's definition in an article in Academic Medicine. It was an editorial on physician resilience. And let's read their definition, because this one works for me, certainly. Resilience is the ability of an individual to respond to stress in a healthy, adapted way, such that personal goals are achieved at minimal psychological and physical cost. The stressors are not going to go away. What's going to go away is how do we prepare people to handle it. That's going to change. And secondly, resilient individuals not only bounce back rapidly after challenges, but grow stronger in the process. And so you think about the tree that needs the wind to bend it in order to become stronger. That's resilience. That's not simply adapting, that's actually growing. And so now, that's what we want our students to be able to have as they enter this profession, because it is challenging, and you certainly know better than I do what you're facing. Now, the reason that I wanted Southwick to come is because his idea was resilience is not limited to an elite few, and I also want to tell you about that. And I'll show you the quote again. His research, his working hypothesis was that there's something about people that are highly resilient, and he wanted to know what it was. And he studied 3 populations of individuals. He studied former Vietnam POWs that actually survived the incarceration, came back to society, and thrived. He studied special forces instructors that, to his mind, were fairly resilient individuals. And he also studied individuals that suffered childhood trauma and also were able to withstand that and come back into society and lead productive lives as adults. And his working hypothesis, there's a secret sauce. What is it? Well, his conclusion was no. This is the quote I want to show you. Anyone can learn to become resilient, and that's what I wanted to hear. What is that? And so you want to know it too, right? So here's his 10 things that he had listed. What are the elements of resilience? And so as you go down this list and say that, virtually every group that he's looked at exhibited these characteristics. They had positive emotions. They used humor and optimism without being Pollyannish. They were able to regulate their emotions. They each exhibited a coping style that was active as opposed to passive and avoidance. Many had social support, had cognitive flexibility. I talked about this yesterday with students, the ability to reframe negative situations into, you know what, it's not so bad kind of thing. And they have, most had a spiritual component to their lives and a moral code, and resilient role models made a big difference. They all had purpose and meaning in what they do, which was facilitated by colleagues. And ultimately, they did have training, both psychological and physical training, to prepare them. These are things that we can easily adapt into the way we train and incorporate. And so here's the article that I mentioned, that editorial by Epstein and Krasner, Physician Resilience, what it means. And let me extract for you what they defined as the element of resilience. Individual factors, the capacity for mindfulness, they mentioned, self-monitoring, setting limits, and attitude that promote constructive health engagement rather than withdrawal, right? I mean, after last night's election, there's quite a big segment of the population that's basically saying, I'm done. I'm out of it. I'm withdrawing. I don't care. Right? A lot of homes are going to be up for sale if everybody's moving to Canada. And yet, in the face of adversity, what they're saying is, no, it's about engagement. Exactly when it's difficult. So I want to pick up on this thing here. How did mindfulness slip into here? Like, what does that have to do with this at this point? So before I do that, I've talked now for about 12 minutes. Let's do a simple experiment. I'm a physiologist, we do experiments. What we're going to do is I'm going to ask you to put down your cup, put down everything in your lap, because I'm going to ask you to sit in your chair and actually allow your eyes to close. We're going to do a 3-minute exercise. And if you've done this before, make believe you haven't. But here's what I'd like you to do. Both feet on the floor just for a minute. Hands wherever it's comfortable. Let's just take 3 cleansing breaths. And what that means is breathe in as fully as you can and slowly exhale. And try to breathe in perhaps through your nose and exhale through pursed lips to extend your exhalation. Just a little longer now than your inhalation. And let's do one more time. Breathe in and exhale at your pace. And let me invite you to imagine that you're standing in your kitchen. Just take a look at this place. The kitchen is spotless. Everything is in its place. And take a moment to look around the room and notice the color of the cabinets and notice the appliances. And see if you could detect any sounds, perhaps the hum of the refrigerator, or maybe the running of the dishwasher. And see if there are any smells, perhaps something delicious is cooking in the oven. And as you look around the room, walk over to the counter where you see a cutting board and a knife. And on the cutting board sits a plump, ripe, juicy lemon. And go ahead and take the knife next to the cutting board and take the lemon in your hand to feel its texture and its weight. And then with the knife, carefully cut the lemon in half. And feel the resistance to the knife as the lemon splits. And it's a juicy lemon, so some pulp might have spurted juice onto the cutting board. And pick up one of the halves, and with the knife, bisect the half. So now 2 wedges have been formed. And you might have cut through a seed or 2 and more juice has pearled on the surface. And pick up one of the wedges and notice the pale yellow pulp and the white part of the inner peel. And bring the wedge to your nose and see if you could detect the scent of this sour fruit. And when you're ready, go ahead and take a bite out of this lemon wedge. And just hang with that sensation. Oh, what's it like to taste this sour fruit? When you're ready, go ahead and put down that wedge. Step away from the counter and come back into this room and come join us, because we're back here. And if you wouldn't mind looking at me so I know you're back. Pretty much everybody's back. Anybody have any trouble visualizing a lemon? No problem? And the kitchen was very familiar? Were you shocked that it was spotless? I've added that now because some people said, oh no, it stressed me out, the kitchen was a mess. How about, how many could smell the lemon? Just out of curiosity, a few of you. How about taste the lemon? A few more. Anything else happen to you? What?
Salivated, just kidding.
You started salivating? You started how many people salivated or felt the little thing? Actually, more did that than tasted it. That's amazing. So I have some sobering news. There's no lemon. There's no lemon in this room. It doesn't exist. It only exists in your mind as an image, right? So what just happened here? What happened here was very simple. You remembered what a lemon was because your hippocampus knows all about lemons. And your amygdala loves lemons. For some of you, you hate lemons. I was watching your face cringe as you put a bite in there. Here's the olfactory bulb where some of you sensed it. Now all these segments are hardwired into your hypothalamus. And so whether you love lemons or hate lemons, the reality of what happened is your brain knew you're going to take a bite out of something with a pH less than 2. And so immediately, salivation started. Now, what does this actually demonstrate? Pretty obvious. Our mind and body are connected. When I say mind-body, when we say mind-body, it's not an abstract term from California. It's a hardwired connection. Our mind perceives, senses, and can influence the hypothalamus to execute function. Now the question is, what do we do with this? Do we just learn a trick? You're going to go home, you say, I got up at 7 o'clock, this is the coolest thing. Close your eyes, we're going to try this. Or is there something powerful here that we can harness? and obviously that's what I'm after here, is that we know that we can influence processes out of the brain, and the question is, how are we going to use that? And so how does this little thing we just did relate to mindfulness? And mindfulness is, a new age term. Time writes about it. 60 Minutes does a segment about it. I don't know how many of you saw Anderson Cooper meditating and John Kabat-Zinn teaching him how to do that. And the question is, okay, so this is like everybody's talking about it, but what is it, and how does it relate to stress and burnout? What is this all about? Well, John Kabat-Zinn, who's a molecular biologist by training, and then went to the University of Massachusetts in the 70s and began to teach mindfulness-based stress reduction to patients suffering chronic pain that really had no recourse. His dean at the time, James Dolan, who was a cardiologist, this hospital and keep me posted on what you're doing, because other people thought they were crazy. But that dean actually had some guts. So what John Kabat-Zinn said is very simple. What mindfulness is, and I've highlighted the key words, it's an awareness that emerges when you pay attention, when you focus your mind on the present moment without judgment. Present moment without judgment. So let's just imagine you came here at 7 o'clock, presumably to hear this because you're interested. And you're sitting there listening, and you're paying attention as best you can. And invariably, and you say, wait, no, I want to pay attention. And you focus 5 more seconds, 10 more seconds, and then you're thinking about what's coming up at 8 o'clock and what your day is going to be like and things that you got to do. And you're nauseated by last night. I mean, whatever the issue is, you can't help it. And so what Kabat-Zinn is saying, focus in the present, not in the past, not in the future, in the present, and without judgment. The reason without judgment is because what you're doing is not saying, I'm going to be the best meditator. I'm going to really focus. It's more like, what's going on now? And just notice what is, not what you want it to be. That's a new skill. Well, the reason this becomes interesting is because this is now the beginning of the good news. The beginning of the good news is, here's a paper that was published in JAMA in 2009. Let's read the title, Association of an Educational Program in Mindful Communication with Burnout, Empathy, and Attitudes among Primary Care Physicians. So here's an educational program that the group at the University of Rochester in New York offered primary care physicians in that area that scored very high on the burnout inventory. And so here's the intervention. Look at the upper part. They came to the center on Wednesday night for 2.5 hours, for 8 weeks. They had an all-day Saturday between week 6 and 7, and then after that it was a monthly meeting for the rest of the year, and then they followed them 3 months later. Now what do they actually do? They spent the 2.5 hours doing the following. They had a very short didactic component on the deleterious effects of stress, on the importance of self-awareness, on the impact and consequences of burnout. Short. And then they did 2 exercises. One was a mindfulness meditation, again, being present in the moment. And these are 4 different types, between body scan, a sitting meditation, walking, and movement. A mindfulness exercise about awareness, and then a narrative exercise, a writing exercise that focused on appreciative inquiry. And what that's about is focusing on a person's strengths, desires. What are you good at? What do you enjoy doing? What gives meaning to the work that you do? And the idea is, how do I do more of that? But at least identify first what I really care about. And so what this is about is meaning and awareness. That's it. Now, here's what they reported. Now, I took their data, which was all numbers and correlations, and I graphed it so we could watch it. And so what's happening here is a high score in emotional exhaustion, and especially with the intervention, burnout goes down and stays down. Empathy goes up and stays up. They had 2 scales for each of these. I'm just showing you one. And then mindfulness went up and stayed up. And the changes in mindfulness were significantly correlated to the other 2. In other words, the higher the mindfulness, the greater the rise in empathy and the fall in burnout. And that's their paper, and it's published in JAMA, and we're all actually published the paper. But now let's take a step back. So mindfulness and narratives appear to reverse the burnout effects. Why would that work? Right, here's the conclusion. Seems like practicing mindfulness can reduce burnout and increase empathy, but Why? So for that, we got to think like scientists, and so I'm going to give you a hypothesis to think about. Here's the hypothesis. Every day we're beset with stressors, one on top of the other on top of the other. And if we don't cope adequately, what we will propose is that will lead to burnout. On the other hand, if we employ a variety of strategies, cognitive reappraisal, reframing questions, using positive psychology, adding reflection and appreciative inquiry to the meaning of our work, and yes, mindfulness meditation. This is one of several interventions. If we bring these together and cope better, it will bring us to resilience rather than burnout. That's the hypothesis. So in order to begin that, let's think about how do we respond to a stressor. And this is something you all learned in first-year physiology. But let's just remind ourselves what's going on here. So here's what's going on. We have stressors on us all the time. It could be physical stress, emotional stress, psychological stress. It could be a relationship breaking up, or I'm actually physically in pain, or everything in between. The brain assesses the situation and makes a determination, is this a threat or not? And if it determines that it's a threat, then the cascade is the same, no matter what the stressor is. And so CRH is released from the hypothalamus, and ACTH will respond and release from the pituitary, and ACTH goes to the adrenals, and cortisol goes up, being a glucocorticoid, blood sugar goes up. At the same time, the sympathetic nervous system is activated, heart rate, blood pressure, cardiac output goes up, blood flow to the muscles goes up, the fuel is there, glucose has been elevated by cortisol. We have the perfect combination to respond to the stressor. And guess what? This is a very, very good thing. This is how we get through life. This is how we raise teenagers. Now, the system is so good that it's also designed to what? To shut itself off. And so here's cortisol, and cortisol will feed back and shut the pituitary's release of ACTH, and ACTH will feed back and shut off the hypothalamic release of CRH. And CRH will shut itself off through ultra-short-loop feedback. And you've got the perfect system designed that when the stressor goes away, things are good. We're back to normal. So what's the problem? We just said we have a stressor, the stressor goes up, the stressor goes away, this comes back down to baseline, everything is great. So what's the problem? How many of you deal with one stressor at a time? Exactly. Now watch what happens when you put one stressor on top of another one, right? You're all going to see a combination of things this morning. You're going to be hit with things from all ends. Now as soon as the second stressor comes and you haven't dealt with this, look where this level is. It's not at baseline. It's compromised already. It's elevated. And that third stressor comes in, and I don't have to give you, you got your own scenarios of how things pile up. And now you're juggling 3 things, 4 things. And there is a loss of resiliency. Now, the consequence of not having this at baseline means you can't respond adequately to these stressors. We're not optimal. And this is true in physiology and everything. If your renal reserve is not there, if your cardiac output is not there, we're impaired. Cardiac output, you can't do it. And this is no different. And so the whole point is going to be optimal, we have to have the stress hormone levels at baseline. This is what we want. How are we going to get it there? Well, the consequences, first of all, of not returning to baseline is that the entire feedback system is dysregulated. The high cortisol does that. And then we have trouble with the next stressors that we're dealing with at the same time. And chronic stress impairs memory. And I mentioned this the other day, and I'm going to tell you about this as well. And it's interesting that Friedlander picked up on that, if you remember, on hippocampal cells. Well, that's where learning takes place, hippocampus. Now, you ever have this situation, you know, you've got a stressful condition, you either got a phone call or you're rushing and you can't find your car keys. What happened to my car keys? Or, you know, I just had this, I can't find, where is this? You have a temporary memory lapse. So it turns out that when you take hippocampal cells out and you look at synaptic transmission, in the presence of a little cortisol, it's actually better transmission. But in the presence of high cortisol, it's blunted. And you say, let's translate that. Easy. You prepare for an exam. You come in that day, are you stressed? Yeah. A little. Guess what? You're really sharp. Or you're standing up here to speak. Yes, a little cortisol is actually good because you're alert. But if I came up here and haven't slept for 2 days, that would be a mess. I wouldn't be able to think straight. That's high cortisol. So we see that all the time. And so the point is, differentiate chronic stress from acute stress. Acute stress actually gets us through life. Chronic stress makes us sick. So what's going to help get us to baseline? And that's the slide I want you to remember. Out of everything I showed you, that's the one. Get back to baseline. Reboot yourself. And that's where mind-body medicine comes in. That's the unique piece about it. Now, why would this work? We're talking about meditation, we're talking about imagery, we're talking about biofeedback, we're talking about autogenics, we're talking about breathing. How did it feel to just sit here and breathe for 3 breaths? When do you ever give yourself permission to do that? Never. Never. Because we're busy doing, we're not being. I joked with the dean, what would happen if you put a sign outside your door? Come back in 5 minutes, I'm breathing. Would that set a tone? Like you're taking time out to just, wait a minute, I need a few minutes to collect myself. Or if you do that between patients here in this hospital, say, wait a minute here, I just need a minute to kind of rebalance myself. What would that do to you? And for others, it's exercise, or for the others, it's softer, and yoga. And group support is a mind-body therapy because it's healing. And it's very different when you do exercises by yourself or you do it with a group. So when we come back to mindfulness, which I said was that focused attention without judgment in the present, the reason that it helps bring our hormones back to baseline, our stress hormones, is because at that moment we're not thinking about anything else. And so nothing is driving our stress response. We're just focusing on the present. There's nothing there except what's happening at the present. And so the benefits, guess what? Decreased heart rate, decreased blood pressure. What's going on here? It's nothing more than the stress response in reverse. It's the physiology of de-stress. And psychologically, applying this also, I feel less stressed, I am less anxious, less rumination, peace of mind, physiology of de-stress. That's what we're seeing. So, is there any evidence that when you take this meditation practice and you put it in the educational setting, that it affects performance? Let's see.
We send our kids off to school each day so their minds can be filled with knowledge, but clearing the mind, that's the practice one school district is preaching. It's taking time out of the school day for meditation. And by looking inward, these students are finding outward success. The story tonight from NBC's Cynthia McFadden.
At first glance, Visitation Valley School in San Francisco looks like an ordinary, chaotic middle school. But twice a day, something out of the ordinary happens that has changed everything. It is the sound of silence. 8 years ago, in the heart of one of the city's poorest and most violent neighborhoods, the school was spiraling out of control.
There'd be fights here 3 to 5 times a week. The kids see guns on a daily basis. They see all sorts of weaponry. They have that baggage with them.
Desperate, the district tried a pioneering program called Quiet Time.
Ignore the sounds you hear outside, upstairs, in the
The
hallway.
idea, teach students transcendental meditation and give them 2 15-minute periods a day to close their eyes and let go of the stresses in their lives. So did you buy into this at the beginning, or were you a little like, hold it a minute, meditation?
I thought it was a joke. I thought, this is hippie stuff that didn't work in the 70s, so how's it going to work now?
Make sure you switch, good.
But 4 years later, some startling results made the skeptical coach a true believer.
Good job.
A 79% decrease in suspensions, an increase in attendance to 98%, and a clear rise in academic performance. More than 1,500 students and 170 staffers have now been trained to meditate in 4 of the district's schools.
Can you relate to the coach? I know I did. So, and that was a middle school. Yes, it was California. But let's focus on what we just learned. So it looks like mindful practice will utilize the mind-body connection that we have that will de-stress ourselves and bring ourselves back to baseline. I call that the reboot. That's what we need to do, all of us. And you know why? Because we have one of these things. Everybody has one of these things. And you know how this works? Do you know what this does to you? I mean, it's a wonderful instrument, right? We can't live without it. But here's what also has happened. If you have any children, you know how this works. You try to send something to your child, especially if they're teenagers. Yeah, they don't talk on the phone. So you send them a note and you say, call me. Of course, you don't hear anything. So in about 15 minutes, you kind of get a hold of the wife. Have you heard from the kids? They're not responding. And in 30 minutes, you're actually getting agitated. And in 2 hours, you're ready to call the police. I mean, this is, we're on this scale of response that's really problematic. And that actually has an effect on us. So we need these reboots to kind of bring us back to baseline because we're always jacked. So is there any evidence that mindfulness itself can actually reverse burnout? Yes, we have the Krasner study, but I want to share with you 2 other ones in 2013. There's a very interesting group here. So here's the study in Annals of Family Medicine. This is Dave Rakel's group. And what they did here was they looked at 30 primary care physicians and they gave them a very short Here's what they found. Physicians participating in an abbreviated mindfulness training course adapted for primary care clinicians associated with reductions in indicators of job burnout. They learned mindfulness and burnout went down. They felt better about what they're doing. And in the same issue of the Annals of Family Medicine, here's a multi-center study of physician mindfulness and healthcare. Now here's what they did. They had physicians and nurse practitioners and physician assistants. 2 independent variables. They asked physicians, how mindful do you think you are? And they asked the patients, rate your patient-provider communication. All right, 2 separate entries. What you see here, clinicians who rated themselves as more mindful engage in more patient-centered communication as judged by the patients and have more satisfied patients. The exact opposite of burnout. So these 2 studies come out in September of 2013, and here's the New York Times and Pauline Chen writing this, Easing Dr. Burnout with Mindfulness. That started the conversation. And 600 people are on our blog, because I remember that week, I was preparing a talk that week, and I'm reading her blog, and people are saying, you know what, I wish I had this in medical school. Or, this is what I've done to stay in the field. Or, I left the field because I didn't know about this. So I turn to deans and I say, so is this what our next graduate is going to look like? And my answer is yeah, maybe not sitting like this, but certainly giving people the tools to understand how to cope. I think we have the responsibility to do that. And if we go back to Colin Chen, who had the 5 drivers of what's driving burnout, on this slide what you see is here's what an individual can do and here's what the organization can do, some strategies. So it's not going to be solved with 1 or 2 or 3 things. This is a complex problem. But what I do want to focus on is what can an individual do for work-life integration? Learn some mindfulness. And what can gain some control is stress management, resiliency, and mindfulness. And add meaning to your life is through reflection, self-awareness, and yes, mindfulness. The word appears 3 times on that scale. And so at least one intervention is learning some of these skills. It's not going to solve the entire problem. It's not going to solve the electronic medical record. It's not going to solve the overload, but it's going to at least give people some tools, and that's what this is all about. One of the problems in medical school is that we see a progressive decline in empathy. And this is data taken from the University of Arkansas in which they followed a class as they marched through school and watched this progressive erosion in empathy. Let me skip this, but I could tell you that here's the problem in medical school. With this paper that came out 2 years ago, Distress Among Matriculating Medical Students, here's the stark reality. Medical students begin medical school better adjusted than age-matched college controls, their peers. They come to school better adjusted, and that quickly reverses and never comes back. And so the findings of this erosion and the distress, coupled with studies demonstrate high rate of distress among medical students, support existing concerns that the learning environment and training process contribute to the deterioration of mental health in medical students. And you say, what a stinging indictment of our schools and our training. And then there are those that will say, well, this is tough. If they can't handle it, this is not for them. Or, can we do things a little differently? Does it have to be abusive? Does it have to be this? Do we give the students the tools? Do they know what they're getting into? And have we done our job as educators? Because that reversal is inexcusable. And if you think there aren't consequences, here's this multi-center study from Mayo and UCSF and Uniformed Services. There are a whole bunch of folks here. This is 7 medical schools, 2,000 students. 52% had elements of burnout. And those students were more likely to commit an unprofessional act. Cheating on an exam, telling an attending I ordered a test when I didn't. Consequences. And yet, when we take a look at medical education and focus on competency and abilities, every school that I know of has this. Look at number 6. Oh yeah, we want students to be aware, we want them to understand self-care. This happens to be Brown's list. They were the first school to move to a competency-based curriculum. And I asked the dean of Brown, so tell me, how do you achieve number 6? Answer. We give a really good lecture in the first year on the importance of eating right, getting enough sleep, and taking care of yourself. Yeah. And my response was, and I'm sure it's very effective. So what we did at Georgetown in 2002 is began a rather unique course. We hired Nancy Harrisduck to come and join us. We had a grant to begin this program, and we began a course in mind-body medicine. And that's what I want to share with you. This is a new intervention at our school. And the purpose was to raise student self-awareness by giving them tools to become self-aware and the context in which to do that. And so our goals are very simple. We want to increase their own self-awareness of all aspects of their lives. We want to translate that to personal self-care. And we want to do this in a non-judgmental, supportive, collegial relationship. I know it's medical school. Non-judgmental, supportive, collegial relationship. That's what we're trying to create. And so the way we do this is we invite students to participate. About 40% of the class will. That's out of 200 students, about 60 to 80. 2 facilitators per group, faculty that we've trained, and the folks sign up for 11 weeks, 2 hours each session for a journey of self-discovery. There are certain ground rules. We establish each session with confidentiality. The purpose is to listen to each other, compassionate listening, no fixing, no advice giving, and no judgment. You can say anything you want. We're listening, respectful. Yes, I'm a course director, but in this room for these 2 hours, I'm a human being like you are. We're in a different place. We're here to share what insights are going on in our lives. And we're going to use the tools after our period of check-in where each of us will go around the room, so 12 of us, 5 minutes each, there's an hour, to check in with the group. What are we learning about ourselves from week to week? What difficulties we faced that we were trying to sort through? And then introduce a new skill and process that. And what are the skills? They're meditation, the guided imagery. The reason the skills are there, A, they're stress-reducing tools, and B, they foster self-awareness. You do an imagery and you have images and you begin to think about what's going on in here as you understand yourself better. It's not for everybody, but it is powerful for those that want to try this. And so this is the setting, and you say, is this medical school? The answer is yes. We have a group sitting here. We have a candle to light, to focus. We blow it out when the group is over. And so what have we found as we've done this? We've found that the participants have reduced perceived stress, their mindfulness goes up, their empathy goes up. The empathy goes up in the mind-body group and not in controls. That the stress goes down in both males and females that participate in this. And when you take a look at the effect size of a change in stress, it's actually fairly robust. Anything above 0.5 for a curricular intervention is impressive. And mindfulness goes up significantly in this group. And positive affect goes up and negative affect goes down. I mean, we're beginning to change these students as they see what's going on here. And when we do a bivariate analysis, we find that, guess what? The higher the mindfulness, the lower the stress level. And then it gets complicated as we try to tease out what is this. So in this multivariate analysis, we fixed the perceived stress level and the mindfulness change to perceived stress to see the combination of these two. Every student comes in at a different stress level. The two together account for 46% of the variance, of which 21% is related specifically to mindfulness. And then what that means, we look at perceived stress in our students, half for the changes are due to things we didn't measure, a quarter is due to their baseline, and 21% could be modified by teaching them mindfulness. That then becomes the driver. Why do we need to bring this to the curriculum? Because this will help students. And it's not just students, it's faculty as well. And in this group, you see a group of facilitators. We did a study to look at what is the impact of being a facilitator. Now, not the students, the faculty. And so we reported last year in academic medicine that facilitators had higher mindfulness scores that were positively correlated with lower perceived scores compared to the general population. And that the faculty reported in qualitative responses to open-ended questions and improvements in communication, increased sense of connection, increased empathy, heightened self-confidence. The faculty felt better about their own work. And this was new to virtually everybody. But it was a different kind of work with students. So their positive effect on students and positive effect on the faculty. And so we started this in '02, so 14 years, we've trained over 100 members of our faculty to lead these groups, many students, nursing students, graduate students, medical students, and now it's expanded into the law school and into the business school. So it's gone to lots of different places, over 3,000 participants. And so the program has expanded for level 1 for first years and level 2 for second years, and which are offered weekly, and then these are monthly, and there are lots of things going on. A faculty group to get exposed to it, a training program to create new trainers. It's expanded through the university. And then what it's done to our school, as the AAMC reported in 2008, is that it actually changed the culture of medical education, this particular course. Why? Because the dean came to get trained. They're saying we're onto something here. So we've expanded the training now. Twice a year we invite people, 10 in each training, to come from different schools who want to implement this at their school. And so here's a list of the schools that have begun to implement it. We also have it for residents in anesthesia, and Stanford actually was before us to implement this course into anesthesia's residency. And there's some, as you see, schools in Europe that have adopted it as well. And so people are reporting, this is Charité in Berlin, not quite the touchy-feely group you might think. But here's what they write: making better doctors, using mind-body medicine as self-care in medical education at Charité. And here's a group in Australia that's been doing this before we have, enhancing health and medical students, outcome of an integrated mindfulness program. And our data experience suggests that self-care in the form of mindfulness-based stress management and lifestyle can improve student well-being even during high stress, giving students the tools. So let me wrap up and say, what have we learned? We all know that faculty and physician stress and burnout is serious. I would argue that when you look at medical students, that entire piece of burnout and stress is on a continuum that starts way back when medical students get cynical and you see the decline in empathy. That mind-body medicine is nothing more than the physiology of de-stress. It's employing a mind-body connection, and it has salutary effects on our health because it brings our stress hormones back to baseline with practice. And approaches that can modulate stress, mindful practice, enhancing self-awareness, finding meaning in work, the appreciative inquiry, and that these elements have to be fostered, both the curriculum and the culture. So what's my advice? What's my suggestion to institutions? Here are the next steps. You haven't seen this slide. Here's the next steps. Establish a faculty-student task force and figure out what's going on at our institution, what's going on in our hospital. I think you actually just did a survey here. If there's a consensus that a problem, first of all, if there's no problem, report that, because everyone will flock to Rona. But if there's a consensus there's a problem, there should be a collaborative effort. Let's figure out what we do about it. Recognize that the status quo is not acceptable. Remember, this is a moving train wreck. So there are many effective approaches. I don't want you to leave here thinking there's only one. There's several. I'm only addressing the mind-body because that's what we implemented in the last several years. It's also important that participants don't feel marginalized. Someone comes and says, you know what, you need to go to that program. No, this is about all of us. And so develop programs, assess them, report, and disseminate. It's going to take courage, but it's going to take people stepping up to take the lead. Now the good news is, if you do a program, next year, next October, we're doing this meeting again. And I'm very anxious to have you come and present. Tell us what you're doing. Tell everybody what you're doing, because it's an important issue. And lastly, I'll tell you that the AAMC has a new page on well-being in academic medicine, because it's on the radar. And here's the ACGME, all the residencies, and this is their physician well-being page. Everyone is looking for solutions. This is a pervasive problem. Let's see what we can do about it. I want to thank all these folks that I'm listing here, particularly Nancy, who directs our program, and this was the part of the program committee for the Cental Conference. It's all good. We're out of time. I would do a short meditation, but I think you got to get to work. So let me close and thank you for listening. How's that?